those issues. So now I will hand it over to Roger, who will continue our leadership dialogue.
Great. Thank you, Wendy. I'm actually going to build on some of the CHI work and try to tie it into the impact and clinical significance of some of our work together.
Roger, can I interrupt real quick?
Yep.
The slides you have are slightly altered to what Roger has that we'll be presenting on the screen, just so you're aware. It might not be exactly the same.
That's my fault. I updated in the last minute, and they'll be posted to the portal. Oops, let me go back here. Building on these themes, and maybe for Pat's benefit, welcome to the group. This effort of collaborating as a large community began several years ago, but it was a year ago March, that we had a face-to-face meeting and kicked off this collaboration across organizations. At that time, there were a whole series of topics and opportunities and issues that were articulated for which people had priorities, and based on those, that's where the various learning models have rolled out. One of the success factors in large-scale collaborations and smaller-scale collaborations is leadership. Leadership's ability to drive the improvement, sustain the improvement, overcome the barriers, figure out how to collaborate across the environment. And so this leadership track was built into the WPCC meetings. And each month we've been taking a different module or topic and working through it to help support the work in the field. So that's why we're here today. And I'm going to build on that. In that spirit, I'm going to be focusing on leadership's role as a convener and an influencer, influencing in an environment when you don't have control over the variables. All of you are struggled with limited bandwidth, time constraints, organizational capacity, and resources. I think it was Melody who said, we can't do this on our own. We have to figure out how to leverage and collaborate across the environment, how to leverage other resources. So we heard at the summit, Dr. John Powell gave a series of presentations that I thought were fairly powerful. I wasn't there, but I went onto the website to hear the presentations. And he talked about othering. We tend to identify social groups as these others and bucket them and then try to throw these all or nothing strategies at these groups. We try to apply universal principles without really understanding the needs of the individual groups, without tailoring our interventions, our activities. And came up with this term about targeted universalism. How could we start to target these efforts as we move forward? And we talked earlier in the meeting that in the fall we hope to accelerate a more population land focus and the possibility of addressing a couple of core diseases like depression, diabetes, that all of you have articulated as the highest priorities. So if you think of these concepts and you think of what we just heard, how might you be able to target and translate all this theory into action? How could we leverage work across the environment? What I'd like to do is tell you a couple of stories. Some of these stories I shared way back in March, but they may have been out of context. So as you hear them, if you've heard them before, think about them in the context of what could we do here as a WPCC, and specifically to attack diabetes and depression. Okay, so I'm going to tell you about a story about dolphins. I'm going to tell you a story about one individual in a small town in England and how she transformed a community. And then we'll do some other references. I threw up here just a quick reference of what might be possible. In Lafarge, Wisconsin, 92% of women after a C-section have a natural childbirth following that. National average is 8%. Now, that happens to be an Amish community. And in the Amish community, they targeted their interventions specifically to those households, and collaborating across the environment, they're able to achieve those results. And one of the concepts that I want to throw out here is the concept of abundance. Abundance is identifying what are the rich opportunities you already have and resources you already have in the environment. We're not getting a lot of new resources in. So how do you leverage the existing resources? So Marshall University in West Virginia is an example where they had a program with children with severe disabilities. And they were trying to introduce case management and care coordination to these population of children, and they just could not recruit or find any care managers and case managers. They said, where are the abundance of that resource? Where could we tap into that? And what they discovered is that children that reach the age of 18, they're either mainstreamed or they're in institutional facilities. But those mothers have gone through 18 years of perfecting the art of case management and care coordination. They've learned how to navigate every aspect of the environment. And they were an abundant resource in the community. So they went after these women who had reared children and got them through the system. And these children were either in long-term situations or mainstreamed, and turned them into a workforce of care coordinators. That's the concept of abundance, trying to find that abundance in the community. So let's see. How do we get to the end here? Let's see. Somehow we got to the end. So let's start over here. So this is a story of a former vice president for AT&T that helped them win the National Malcolm Baldrige National Quality Award. And I actually met Phil Scanlon in a Baldrige training back in the late 80s, early 90s. And he was talking about going to the beach. And he was very excited that he was going to the beach. He happened to be from New Jersey, lived in Morristown, New Jersey. And he was talking about, he was taking a risk, that he was taking his family on a vacation, and he rented a beach house with no television and no phones. And he was bringing a house full of teenagers with their friends. So he said, this is my risk, and I can't wait. It's going to be fun, and we'll have a lot of quality downtime. Well, they got to the beach, and it rained for several days. And so by the time the rain passed, the kids were climbing the walls, and his nerves were frayed. And finally, they got to go down to the beach, and they walked down the beach with all their chairs and umbrellas and equipment, and there were large signs, beach closed. And the 5th day, the 6th day, the 7th day, the beach was closed. And it was due to in theory, it was due to pollution, high bacterial counts. The public health department has shut down the beach because of high bacterial counts in the actual sand and soil. There were also needles that had washed up on the shore, and there was debris all up and down the coast. And then that following Saturday, 749 dolphins washed up dead on the Jersey shore. On the way home, the kids were talking about, this is the worst vacation we've ever had. This is just horrific. And Dad, what are you going to do about it? Dad, how are you going to solve this pollution problem? And Phil was like, who do you think I am? I mean, I can't possibly solve this pollution problem. And he thought about it all the way home, and he said, what would it take to solve this problem? How can I go about tackling this problem? So he went to his CEO and asked if AT&T could take this on as a community project, and he was rejected. He was basically thrown out of the office. He said, if you want to work on this on your own time, go for it. And yeah, you can use the conference rooms if you want to, but you have to do it after hours, and this can't cost us anything. So go see what you can do. So Phil sat back and did a little bit of homework, and he says, I'm going to take a classic quality improvement approach to this, try to do some root cause analysis. I'm going to identify who the key stakeholders here are. I'm going to try to come up with some measures of performance. One of the measures of performance was beach closure days. How many beaches in each of the little towns were closed during the course of the time period? They started off with 855 beach closure days, and they estimated who was impacted by that, 1.8 million visitors, and the lost revenue from tax revenue and sales, hotels, and others was $800 million that summer for the state of New Jersey from this incident. So it began a journey. He worked with the federal government, 2 state governments, 4 counties, 90 individual shore municipalities, the city of New York City, and the businesses that were all affected by this issue. What they determined determined were a couple of factors. One was that 95% of the closures, the actual reason for closure, was due to deteriorating storm drains. Now, these were old terracotta storm drains that were built in the 1800s, and underneath the streets leading to the beach, they were cracked, and so sewage was seeping out and going into the beach. So they worked with the Army Corps of Engineers and the state of New Jersey to start to survey how many of these, and then what could they do to address it. Secondly, they found there were 2 trash haulers in New York City that were taking hospital waste down the Hudson River out into the Atlantic Ocean and basically dumping it off the Jersey Shore. So all of those needles and trash were washing up on the Jersey Shore. And the third, you see a picture here of some old boats. What they found was that the piers in New York City that were built in the 1800s were rotting, falling apart, and drifting down the Hudson and then landing on the Jersey Shore. So now they had 3 identified root causes, and then based on autopsies of the dolphins that the state had identified, what they found was the dolphins died from something called an infection called crabatoxin, and it was from the tribunal tin that was in paint for pleasure boats. So this paint had been introduced. They were all painting the boat's bottom, and this was leaching in, causing a bacterial uptake, and then killing the dolphins. So they decided, where are we going to get the money? So they worked with the state, and they came up with a campaign called Shore to Please. These were vanity license plates that were sold, and they were built by the Bureau of Prisons, and they were sold to raise the money to start to address some of these issues. They created totally voluntary infrastructure of different communities and businesses coming together. They put it in a transparent measurement process to feed back what was actually happening. They engaged the Corps of Engineers, and they engaged the prison bureaus, both in New York and New Jersey, and it was actually prisoners that went in and took out the old pilings in the harbor and then had them rebuilt. They were able to prosecute the illegal dumping from the hospitals, the trash haulers. They raised $1 million in the license plates that helped them begin to fix some of the drainage systems. Again, they worked with the Corps of Engineers. They passed some legislation on the tin, and as I said, they used the prisoners in New York City. And as a result of that, the beach closure days went from 855 to 40. It resulted in 50,000 jobs. Many of those were lost because of the prior season. $600 million in new taxes, and at the end of this, AT&T threw a banquet for everyone, claiming credit, of course, for this wonderful thing that they did. But that cost them $2,000 for the award dinner. Now, I thought this is a very powerful lesson of being able to tackle the impossible, nothing. But starting with a vision, starting with a will, starting with identifying what targeted interventions do we need to make, and then leveraging the abundance in the environment. Really understanding what stakeholders are most affected by this and engaging those stakeholders. The second case study is comes from Penwares, England, and was called the Beacon Project in Old Hill Beacon and Old Hill Estates in Falmouth and Cornwall, southern England. This was affectionately referred to by the locals as Beirut. It was one of the worst poverty counties in England. Horrific violent crime, mistrust, drug dealing, intimidation. Lack of heating in many of the homes was causing asthma and respiratory problems in the community. 50% of the homes in a particular town were without any heat, and so they were burning wood and coal in fireplaces, which I hear is an issue in the community here. And their illness rate across the board was 18% above the national average. Hazel Stutley was a community social worker that worked with perinatal area and was trying to deal with a lot of postpartum depression and issues that were associated with that in the community, and also with child abuse and the number of children that had to go into a register system and then placed into foster homes. So she was getting increasingly frustrated in her own role as just every day, it just seems like this is a never-ending problem. There's just one family after another coming up with more social determinant of health issues, trauma, more adverse childhood events, and I don't seem to be getting anywhere. So she decided to shift tact and they decided to engage the local community. Again, identifying what's the abundance. The abundance were the mothers of these families that are dealing with all these social determinants who wanted something to change but felt powerless. So she went out and did interviews of women across the community and found 20 women that thought had the interest and passion and leadership skills, but out of that found 5 that she thought could really start as a small coalition, pull together the community residents and work together. So they worked on mapping what are those homes that don't have heating and could be addressed. And lo and behold, found out that there was actually some government grant money available that they could go out there and start to address those homes. As a result, they installed energy efficient heating and insulation, again, a very targeted intervention. But they also decided that while they're into these homes, many of them were very dilapidated and they needed new insulation. They needed new outside clapboard. And they said, while we're doing this, why don't we change from this dreary gray town that we live in and start to paint these homes all bright pastel colors, bright turquoise and orange and yellows and all of this. And as they started repainting the town, all these homes, all of a sudden they saw the mood of the town starting to change. The affect, the spirit starting to change of the community. They looked at the literacy issues and the lack of employment, and they said, well, where's the abundance where people gather? And they said, well, they gather in the pubs. So they installed computers in the pubs, began training people computer classes and the skills to do that. They developed a fundraising program in the community and for those around the community. They built a community resource center as a place for the teens and others to gather. The impact of all of that crime fell. Burglaries were down 34%, violent crime down 50%. School exams of the children rose 18% for that middle school age group. A 58% reduction in those child protection registries. The core of Hazel's work was finding these families and getting those kids registered. 77% in postnatal depression reduction in that community. And unemployment fell by 69%. So here again is a situation of it just seems absolutely overwhelming, absolutely impossible. Where do I start? I start by really understanding what the issues are, going out there and engaging the community, identifying that coalition of the willing, looking for the abundance, looking for the resources that already exist. Her statement was, we built up people's self-esteem through leading from behind. We were the enablers. We only take credit for kickstarting it and getting those people to a level of self-confidence and self-belief that they could carry on. And now, nearly 2 years down the line, they have been able to sustain the work. So in this resource-constrained environment, the question is, how might we? We're going to tackle depression and diabetes in the community. We can't just do it by our own internal quality improvement efforts. Clearly, there are huge social determinant of health issues. And now we have the CHIs that are working on some of these social determinant of health issues. But what can we do to really leverage those issues around depression, diabetes, clinical issues, and what abundance might exist out there? So I just pulled into my resource glossary of what programs exist out there, what abundance is already in place across the country and in local communities addressing diabetes and depression in a variety of ways. So there's a lot of community coordinated events. There's a national program called Girls on the Run, an after school program where girls get together and the mothers lead this and they train over a course of a season, and at the end they have a little mini 10K that the families all run together. But after school, getting these kids together in these cohorts ends up building their capacity, and they started weaving other educational programs on managing obesity and diabetes and other things to help build that cadre. In Parkersburg, West Virginia, they have a program in the morning before school called the 1 Miler. The kids voluntarily showed up. They thought they would get very few kids. Most of the kids would show up before school and start this 1 Miler program. It became a socialization issue. Again, getting these kids activated and engaged, addressing some of the core obesity and activation skills. So you see there's a whole series of programs. The Stanford Chronic Disease Self-Management Program. How many of you have heard of the CDSMP program from Stanford? Any in the room? Few people? Yeah. So this is a national program developed by Kate Lorg. It was actually embedded in the national CDC primary diabetes prevention trials. It was one of the most successful arms of the trial. It's a community-based program over 10 sessions where they bring cohorts of people with chronic disease. The focus was diabetes. And through multiple sessions combining exercise and diet counseling and working with them in an outpatient setting, these were done at the YMCA. The YMCA now has a division of chronic disease, a medical director for chronic disease. They've been looking strategically across the country of what is their role long-term in managing and helping with chronic disease. Again, partnering across the country with local clinics. A lot of FQHCs across the country have partnered with the YMCA as well as other clinics. So those are examples of community-based events. The right-hand side are hospital clinical coordinated activities. ARCare is a successful primary care system in Arkansas, very rural communities, and very challenging social determinants, similar to some of the ones that you are challenged with. And they looked at what abundance is in the community and found that the school system, because the population had declined, because people moving out of the area for jobs, there were many abandoned schools that were sitting there. And so they went to the school system and said, what would it take to turn over the school to us? And we'll convert the gym into a community center, build a teaching kitchen, and start an exercise program and see if we can work with our local town. Well, that initial pilot led to them expanding that model and spreading it across the different communities. So again, a large capital asset sitting there vacant, being able to go in and with minimal expense working with the county, able to refurbish it. You see a lot of other programs up there. There are many of your organizations do workplace wellness clinics, whole variety of different programs. Scripps in the community has a Project Dulce, which is a diabetes-focused effort where they are the convener and trainer, but really the community helping to run these programs. In Minnesota, there's the Alliance for a Healthy Generation. In San Diego, I mentioned Dulce in San Diego, Wisconsin, the 21st Century for Community Learning Centers, after-school programs where they partner with the community and the care teams to look at how they can provide activities after school for all of the kids to build health literacy, engagement, and activity, specifically focused on trying to reduce diabetes and other related events. Sibley Hospital in Washington, D.C. started this Taste and Talk program where they put up community grants for individuals and communities to apply for how would you tackle the issue of food deserts and diabetes in your community. And this one couple, a sister team, took on this program and designed something called Taste and Talk. And it's a 4-session series where they bring neighbors in, 10 women, into the house, and they cook them a low-carb, basically plant-based meal, teaching them where to get the source of the materials and how to cook materials. And when they bring these women in, they cook enough that they have a goodie bag that they have to take back for the rest of their family. And as a result of that, they end up really engaging them. So these are all just a myriad of examples. I have a resource at the end that's a catalog of 30 or 40 community programs around the country that represent abundance. Models are there. It's a question of what needs to be done to bring them together. So where is the abundance in WPCC land? What programs are out there that you know? Let's take diabetes as a start. What programs are you aware of in this community that are already out there trying to tackle diabetes that if we brought them together with your work might result in really being able to accelerate improvement of the community? Any payers, for example, may have targeted diabetes programs. There could be other community events. Is anybody aware of any program in the community, diabetes program?
You guys still doing it?
CDSMP, so you're doing that version within your system?
Oh, it's a community.
Oh, it's a community? Okay. Right.
WPCC has some classes, like I don't know, But our nutrition services and behavior folks come together, and they're for kids who are in danger of diabetes, pre-diabetes. Have those classes, and I think they go for it. Healthy Adventures, yeah. Healthy Adventures.
So Healthy Adventures program, we heard, and then we heard the chronic disease self-management program. Can you describe that working in the community? What's involved with that? Oh, she's good. She's not going to make you put up the sign.
So ours is a peer-led program, and it's 6 weeks. And so it's just different people, either family members or people who themselves have chronic disease. And Caitlin Cork, who is my coworker, is the one that leads us, or coordinates them.
Super. Any other thoughts? Any other programs? Any of the payers sponsoring programs focused on diabetes for their other payers?
I know Coordinated Care does have diabetes management for our members.
So you have a whole series of
Yes.
collateral material and support, and could be telephonic, web-based, other
Right,
kinds of
telephonic.
activities to support the members. Okay. Any others? So those are just 2 or 3 quick examples of abundance in the environment where people are working on programs. Yes, someone else?
As we have a behavioral health diabetes combined group. We have group visits basically that we bring up every 8 weeks or so. And
So you're doing group visits internally in your organization where we're bringing people with diabetes together and then supporting them. And for that, you've had to develop educational material and coordinate that so that they're not just sitting around, but they're really benefiting from the model.
we do that for depression management.
And you do it for depression management as well. Okay, great.
Family Health Centers has 2 tracks for that type of a group visit. One is put on by lay leaders with our community health workers. That's more of a support group. And then we have our group visits with a provider that are behavioral health integrated, where we have a behavioral health provider and a primary care provider. And those are meeting monthly, where we haven't perfected it yet. Unfortunately, we're still having to, again, have a foot in each camp with how do we bill for these, and we're having to, in essence, kind of dumb down the process in order to get paid for it, rather than being able to do it as well as we know it would work if we didn't have those same constraints. But we've had really great feedback from the patients who have been involved with those health integrated diabetes groups, and it has actually uncovered some of the depression things that we were not recognizing with our diabetes patients.
Fantastic.
And the one nice thing about having the 2 tracks is that way for our support groups that are led just by the lay community health workers, that there's no constraints on that as far as whether or not they're established with a certain payer or anything else. It's kind of come whoever will, and you don't have the same kind of constraints as the group visits.
Super.
This is Phoebe from Catholic Charities.
Yes.
Actually, later today, I have the opportunity to meet with Community Choice and Molina as far as partnering together for that layperson diabetes education for our case managers. So I'm really excited about that. I wish we would have had this conversation 3 months ago, as I was kind of in the desert as far as where these resources were.
Fantastic. Anyone else on the phone? So think forward to the fall, and let's say you do decide to work on diabetes and depression. Be thinking about how might we leverage all the work that's going on with the CHIs and some of these community resources to really focus and target on those populations where we want to really move the needle. It begins by being a convener, finding within your staff who are those leads, whether it's yourself or someone else that has a natural affinity or that's part of their role. Are they a lead that could be a convener? We could pull a group together. Can we really drill down and start to understand the data like we started with asthma? Can we drill down on the diabetes data in the community and look at the hot spots and the clusters and where there are areas, the segments of the population where we might be able to really make inroads. And then who are the champions? What is the abundance within those segments? If there is a cluster of, let's say, a Hispanic population in a particular community, is that an area where we could tap in some of the local resources and bring them to the table to help leverage all of this? So this notion of segmenting and this targeted universalism, if you will. Identifying what the gaps are. How could we bridge those gaps? What are the resources that optimally would do that? And then really mapping that, as I said, there's that abundance. What are the programs already there? We don't need to reinvent the wheel. Let's leverage them and bring them to bear. Align the silos as much as we can, and then identify any new programs and see if there's some opportunities perhaps to do some rapid prototyping, the application of design thinking and other tools to develop some new programs. So this builds on the CHI conversation. It's a precursor to thinking about the fall. The ask is for you to think about your own programs. Are there champions within your organizations that you might want to think about engaging them and starting the thought process? And as we start to move towards a more concrete plan in the fall, could we put together a group of conveners to start to figure out how to leverage all this abundance and these resources and come up with a novel program that really takes advantage of your internal QI efforts, external social determinants efforts, and targeted interventions leveraging this abundance in the community. Any questions or comments or observations or reflections based on what I just said? Does this resonate at all? Is this too abstract? I see some nodding heads. Any other thoughts or comments? Anybody on the phone?
This is Jamie again from Catholic Charities. I think it would be helpful on our end. We've had really good success in working with AmeriGroup. They've been able to coordinate with us and get some programs going for our staff and for our clients. It would be good to have some of those other resources available to us. Like if Coordinated Care has a program for diabetes, I sure would like to know how to access that for our Coordinated Care clients.
So part of the work that could take place is to really catalog all of these resources in abundance and pull it together so that we can really take advantage and focus and understand what is really the meat behind the models and how to then really scale it across those segmented populations. And again, this is an opportunity for the individual payers to work with their beneficiaries and all of you as contracted entities and try to leverage those resources, and then backfill with some of these other programs in the market and see if we could really move the needle for many of these programs. But again, leveraging what already exists, not trying to ask all of you to contribute a gigantic resources, but how can we really leverage this across the environment? Any other thoughts or comments? Peter?
When he doesn't wave a sign at me. So I'm particularly interested in the connectivity between the healthcare providers and the social determinants. I mean, one of our objectives in the Whole Person Care Collaborative is to, promote work with social determinants. So at the next CHI, we're going to be talking about that. We're going to be pulling together, this is in Okanagan, a whole group of people and looking for success stories or opportunities where people are actually doing this well. As Melody said, it can be discouraging. We go to these seminars and get all excited. We go back and we do our, how do we fill the schedule? How do we see the patients? Write scripts, write referrals to specialty. How do we, who's doing well with this? Who's making inroads? Who has some success stories to talk about in terms of referring and supporting the organizations and social determinants? So heard from Kelsey about, we are doing Stanford model on living well with chronic disease and all that, but how many provider groups are really referring robustly and monitoring patients and supporting them in that process? That's what I'm interested in. So if people have best practices they want to share, I would love to hear about it.
Wendy, I'll turn it back to you.
Thanks, Roger. That is the thing that I've heard from several in the site visits, Peter, is trying to address social determinants, screening patients, yet when you find there's an issue, what do you have in your community to support that? And many times there's not a whole lot in the community to support that. So what can you do to partner with, say CHIS, because the CHIS is that Coalition for Health Improvement, to start to address some of those issues. Where are the gaps in the social determinants of health, or assisting those patients to addressing those social determinants of health, and how can you as a community help address those? So I think those are some examples. I'm going to move on. Anything else anyone wants to share based on what Roger has talked about, what we're doing as a WPCC within our change plan, experiences you've encountered? Okay, we have 10 minutes, 12 minutes, or no, we got a 45, my math is off, 7 minutes. Let's do a quick roundtable of what's going on, successes that I heard a lot on my site visits, so don't tell me you're gonna pass, because I know better this time. So I'll start with Blake, since Melody had the floor, and don't forget your microphone.
Let's see, well, we, transitioned our specialty behavioral health providers onto Athena in December, and so we've continued to improve the ways that they're engaging with PCPs and other providers in an integrated way. That's something that we're continuing to improve upon. We are also, we made some adjustments mid-March. We began 1 day a week to dedicate one of our behavioral medicine providers at 600 Orondo all day with the pediatrics providers in order to do some targeted work there on the day that all our pediatric providers, 600 Orondo, are on site. And then we're going to do the same thing at Columbia Pediatrics starting next month, 1 day a week, having a dedicated BMED provider. So yeah, so we're in the midst of innovating.
And that work started with that behavioral health plan, is that correct?
It did.
So you know that some of the work is continuing past the lands. And I remember being at their site when they said, we haven't even sat in the same room together for that one session. So I think there was some talk, but not actual meeting. That's great work that you're actually implementing.
So Columbia Basin Family Medicine, Ephrata, we started doing social determinants of health screening in April. And we've been building our care coordination program for the last 2 years. And in the last 90 days, we started the community health worker position. And we trained her to be assisting the care coordination and things like that. But in the social determinant of health screening, we've come across individuals who don't have phones. And how do we reach them? Well, fortunate, we have a community health worker that we can send to the home, but that's not a sustainable fix, at least not yet. We haven't figured it out, but that's something that we need to do some work on.
Nice work. Kathleen?
I think there's no big thing that we've been doing in the last several months, except that we're furthering down the road of team-based care and doing everything we can to empower people who have certain skill sets to utilize those skills. So many times we venture onto a community improvement workflow, and I just honestly believe that when you have the right people in the room, the answers are in the room, and it's getting those people to engage and share what their ideas are. So, it's a brainstorming process in some cases, but again, empowering the right person to do the job. And that's helped us expand our chronic disease management. Our nurse who's oversees that doesn't always have the time to do every piece of it, but she's given the authority to delegate certain tasks to other people and engage people like our PSRs who might be, I think you were talking about getting front desk staff to be more engaged with the social determinants, and including everybody in some of our not some, all of our team meetings so that we hear from every area of the clinic. I think, that's what it takes. And one of the keys that we hold is that we have a very engaged medical director who really owns things on the provider side and looks for answers from the MA, from the PSR, from people that sometimes don't feel okay about telling a provider what they need because they think that person knows everything. So it's just that free-flowing communication that's been the best thing that we can offer each other as a team. So I guess rather than a specific process, that's what I would have to say.
Thank you. Lisa?
Perfect.
First time with the microphone, so I'm pretty excited. I knew which button to push. Well, we are kind of experiencing a little bit of frustration when it comes to the change plans because we solved one problem and then inadvertently created another. I guess going into this had this vision that we were, we had all these change plans and, we had these dates and we were going to do this change plan and then that would be finished up and then we move on to the next change plan, and here we are several months later and we're still on our very first change plan. And that's what we felt most important at the time was increasing access to our patients. It was the #1 complaint by all of our stakeholders, and it was the #1 complaint with our clients. So it was very important to us. And we succeeded. We are getting people in the same day that they're requesting services, which we're super excited about that. And now what do we do with all these people? Because they've come in the door, so we've virtually moved the bottleneck from this point in time to now this point in time. And so we have providers with these huge caseloads, and so we're kind of grappling with that. So it's triggering my OCD just a little bit because I really wanted to just wrap this one up with a bow and then move on to the next one. I didn't know it was going to open this huge can of worms. So we're kind of, trying to figure it out. And of course, we've had some significant staffing changes, which I don't know why people have to leave. It just messes with the timeline of everything we're trying to do. But I get it. So yeah, that's just kind of where we are in the whole thing. And I really wish we could clean it up a little bit, but I guess it's not a clean process.
So I have a couple things. And I probably should have said this a long time ago, but I kind of feel like the social determinants of health should be a priority for our change plan, whereas it's been set up as behavioral health, integration, and chronic disease. Maybe it's because I'm a social worker at the heart. But if the idea of social determinants of health is something that could impact or may impact every person in our communities, even myself, I could lose my job tomorrow. So I don't know if this is just diarrhea of the mouth or if it's a statement or a question or what, but it's just one of those things where we had to focus on these social determinants of health, even for you. Mm-hmm. It might move that bottleneck that you have with your therapist discharging people a lot faster. Mm-hmm. But I just at some point would like to see that be the priority in the future, I guess. So, but as far as something positive to share, we've had a diabetes project going on for some time now. I don't remember all August or so. I don't have all the numbers right off the top of my head, but the one number that always sticks with me is that of the population that is being screened and has positive screens, we have 99% of those people are having coordination, continuity of care with the primary care following that positive screen. So
that's great. Thanks for sharing. You guys are off the hook unless you have some burning something you want to share, because we are at the time frame. So thanks everyone for coming, and we will see you in June in Moses Lake.